Okay, well, welcome everybody. It's great to see these little thumbnails. We can all pretend we're in the same room together. I'm super excited that you registered for this event. I'm Caroline from the North Central ACH, and I took over as the project manager for community-based care coordination in March. And for those of you who don't know this, that's one of 6 projects that are ACH selected under the Medicaid transformation. Um, Before I kind of set the stage for why we're here and what we're going to do today, I just wanted to cover a few quick logistics in Zoom. Um, there's a couple things that I think will make things easier for you during this event. And one is to be familiar with gallery view, which I think is what it defaults to when you join. That's the recommended view. So you should see like a giant Brady Bunch. And then the other thing that I like to do in Zoom is to have my chat box open. And if you don't see that open yet, if you hover towards the bottom of your Zoom screen, you should see an option for chat. So I like to open it, and then I like to keep my screen in, I don't want to put it in full screen mode, because when you go into full screen mode, you lose your chat box. So I really like to have it where your chat box is to the right of all the little thumbnails. And that'll be the best viewing experience and engagement experience for you, because you'll be able to watch and also interact and engage via the chat. So that's a tip. And then if you're having trouble with that, feel free to chat John Chapman. John, can you wave? If you see him in the thumbnail, that's John, my colleague. And he can help you with some of the tech issues. And just so you all know, this event is being recorded, and we're going to be sending the link out to those folks who couldn't join us today. We had some people registered who, including a care coordinator, who can't make it today because of the fires. So I hope everybody's really staying safe. Coronavirus and fires together makes for kind of a perfect storm. So I'm really happy that you all were able to join us today. So setting the stage for why we're here. I think, taking over as the project manager for community-based care coordination in March was an interesting time, not just because the coronavirus was about to just cause major disruptions, but also because the North Central ACH chose to discontinue the Pathways Community Hub pilot. And pilots don't always succeed, but they always teach us something. And we learned a lot about what it takes to stand up and resource a really specific program. We learned from challenges around referral processes. And there's still some aspects of the model that may be worth pursuing for our region. And that's something I'm still talking to Action Health partners and I hope to talk to you about, so that we have a strong care coordination network in our region. So as we look ahead, I think all of you here today have an opportunity to work with the ACH to weave together parts, like these little distinct parts of care coordination, into a more cohesive whole. And there are many people and programs doing care coordination, including many of you. And I don't know about you, but for me, it gets really hard to really understand how those programs are similar, how they're different. Do they complement one another? Do they duplicate one another? And it's not until we kind of understand those answers that we can move into how we work together, right? How we make cross referrals, how we partner, and then thinking even about how do we use our resources more strategically across the region. So looking at the registration list for today, I know that many of you are from healthcare settings, so clinics and hospitals. We've got some community health workers, paramedics. We've got some partners from behavioral health and substance abuse providers, some of our managed care organization partners. And then there's a number of you who are not from the healthcare setting, which is great because we need to work together to address the social determinants of health. And I saw a couple of folks on the registration list from housing, transportation, food assistance. So welcome. We're happy to have you here. And I'm betting that most of you, in some shape or form, coordinate services to support the healthcare and social needs of clients. So you're all a piece of the puzzle when it comes to promoting health and wellness for our communities. And today we're going to dig into one program, Health Home, right? Not home health, Health Home. This is already one point of confusion for myself as well. And I would say that Health Home is not widely understood. It's a community-based care coordination program that's been around since 2013 in all of Washington state. And based on a recent snapshot of data, we have about 545 residents of our North Central Washington region engaged in this program. And the briefing and the frequently asked questions that I sent out ahead of time were supposed to give you an overview of who's involved, who's served, and what the program does. And Sahara already did, in the chat box, she put a couple links for you to those same resources that I emailed via PDF if you want a quick access to them. So thank you, Sahara. This is a team effort. So today's session is an opportunity to take things one step further and to really understand why this program matters and how it works. So we're going to start off by using a format called a fishbowl. You probably heard Teresa say that earlier. And this is a great format because it gives us an opportunity to hear insights and stories directly from the true subject matter experts. And those are the health home care coordinators that are doing the work on the ground. So this is designed to be informal. I hope our health home coordinators can pretend they're at a coffee shop together. And when they have their conversation, what's going to happen is all of us listening are going to just turn our cameras off, and the care coordinators will keep their cameras on and talk amongst themselves. And like Teresa mentioned, later on, we'll have a chance to engage with questions from you and also use breakout rooms to kind of reflect. And when you go into breakout rooms, I encourage you to turn your cameras on, introduce yourself, tell people who you're from, because we don't want to miss on the opportunity to build relationships. So normally in a fishbowl event, we would all be in person. We are used to Zoom environments now, but I don't know about you. I am guilty of multitasking in Zoom environments. And what I would encourage you to do today is to really, as much as possible, remove distractions so you can listen with the same attention and passion with which you want to be heard. So turn off your email, set yourself to away, put your phone down, text messages down. All of that will be waiting for you in 2 hours. It'll be there, anxiously awaiting for you. But I recognize too that some of you may need to tend to things, so go ahead. But if you can, really just focus on listening and watching. And then engage with the chat box, share your reflections, your questions, your thoughts. For me, I like to think of the chat box as kind of our collective stream of consciousness. And I'm definitely going to look at a lot of things that you put in there to shape some of our activities and work going forward. So I'm looking to mine that information. So please share, because we as an ACH can't figure out what to do to support care coordination across our region without your input. One last thing I'll say before I hand it off to Teresa is that as you listen to our health home experts in conversation, I would encourage you to listen for the following. How does the health home program fit into your care coordination or your case management model? Do you serve similar or different clients? And what about this model makes it community-based? And then how might you coordinate and collaborate with Health Home, right? Maybe some of you already do. Maybe some of you are trying to understand what it really is so you can link your clients to the program. So I think that's enough for setting the stage. And with that, Teresa, I'm going to turn it back to you to introduce yourself and take it away.
Thank you, Caroline. It's just great to be with you all today. And, you know, from here in Seattle, my heart's with North Central. So I'm really happy to be in this via this medium here today with you. And we've got an awesome group of health home care coordinators with us today. And my role is to ask some really good questions, to get a lot of stories flowing. We met last week, we heard awesome stories. We had lots of insights just as we were preparing for today. So I know you're going to have just an awesome day, and lots of things that you will hear. And then even in our time together last week, we were starting to see opportunities for evolving the program. So this is a participatory leadership event where we'll turn the tables halfway through and be engaging you in seeing how we can move both health homes and care coordination forward. So be ready with your questions, be ready with your insights, be ready as you see opportunities for how we can move this all forward. And then just enjoy the conversation here. So if you're not in one of the fish in the fishbowl, then go ahead and turn off your videos, and so you can just be in listening mode here. And then I'm going to invite, we'll have a series of 6 questions, but first just some brief introductions. So I'd love just for each of the health home care coordinators just to share briefly who you are and where you serve, and just like we did when we were together last week.
You want to call us out, or I'll just jump in?
Go ahead, Bill. You start us, and then tag someone else.
All right. My name's Bill Murray. I work for Action Health Partners, located in Wenatchee. My service area, for the most part, is Wenatchee, East Wenatchee. So I go to Rock Island to the south and the BB Bridge to the north, with some cross-care coordination to other communities. I am a licensed counselor, developmental disability specialist, and a certified addiction recovery coach. And I've been working with Action Health Partners since January of 2016. I work 30 hours a week. I have a caseload of 40 clients, and I see all of them every month minimally, more often when there are challenges or crises. My caseload is primarily, well, all of my clients are dual in the sense that they are Medicare and Medicaid, and about 2/3 of my clients have a primary diagnosis of mental health in addition to their medical challenges. Thank you. Midge.
Midge, let's unmute you. Go ahead. You're still muted.
Sorry.
Sorry
About that. I'm Midge Kirkpatrick with Action Health Partners in Wenatchee. I've been here just short of 2 years. It doesn't seem like it. I've been a nurse for 46 years. And as I said in our preparation, I don't wear my nurse hat, but I am willing to answer simple questions from clients. I do have approximately 39 to 40 clients who mainly have chronic illnesses and the ravages of age, and some mental health problems. I work from Dryden to about 15 miles past Soap Lake, and I also have a Quincy patient in the, I haven't used that word for a very long time, a Quincy client in the George area, which is a little unusual, but she is reclusive and doesn't let anyone else in pretty much, so we've stuck with that relationship. I have about 40 clients, as I said. I work about 30 hours a week. And my clients range from in their 40s to in their 90s. And the best part, I think, of care coordination is the relationships that you develop. And I would say Gladys.
Go ahead and unmute Gladys, and you can just stay unmuted if you're in the fishbowl. Yeah.
Gladys?
Now you're good.
Hello? Yes. Hi, thank you, Mitch. My name is Gladys French, and I have been working for Action Health Partners over 5 years. My background is case management. I have experience of over 20 years. I used to work with the First Steps program also, and dealing with high-risk clients. And I work with Hispanic population plus Anglo also. And my passion is serving, and I feel very thankful that my clients allow me to enter into their world and be part of that. And like Mitch said, this program is about relationships and gaining their trust. So it's a pleasure to be here today. And now I tag, I don't know who else is here. I only know Mitch and Bill.
How about Megan or Heather?
Okay, I tag Heather.
Hi, my name is Heather Peterson. I work for Rural Resources in Eastern Washington. I am a training coordinator / care coordinator for the agency. I have roughly 40-ish members every month, and I serve the southern Stevens County and southern Pend Oreille County areas. But we do service a wide variety of counties. And I will tag Sherry.
Thanks, Heather. Hi, I'm Sherry Peterson. I am a care coordinator with Rural Resources. I've been here for about 2 years, and I have about 20 years of experience in medical settings, clinical and hospital settings. I work as a care coordinator, and I'm also the operations supervisor here at Rural Resources. And we serve about 12 counties. We're in Stevens, Ferry, Pend Oreille. We're over in Whitman and Asotin, down to Walla Walla, and then also Benton, Franklin, Grant, Adams area. So many of our members live in very rural areas, areas where access is difficult. My caseload is from ages 2 to 98, and it kind of is, there's a mix that's there. There's people with chronic health conditions, but also providing care coordination and support for families of children with developmental disabilities or with behavioral health issues. And a lot of it definitely comes down to what the resonance is in this conversation. Centers on relationships and trust, and building trust with the members that we engage and with their families, so that we can help them work forward on their person-centered goals. And I'll tag Megan.
Thanks, Sherry. My name is Megan Sullivan, and I am a newly graduated nurse. I am also new to Rural Resources. I work with Sherry and Heather as a care coordinator with the Health Home program for about 2 months. So it's very exciting to be a part of this amazing system that is really empowering people to pursue what is their individual optimal health. My background is in EMS, and having served for years on with a group of people, some of which are in our group today, which is very exciting, in a rural community, that you witness those gaps, you witness the needs that are not being met, and how do you reach out to services, how do you wrap a blanket around people to give them the comfort and support that they need to even think about what's possible, right? They're taking care of that acute moment, and there's something so much, it can be such an isolating event for them if they do not have that advocate, they do not have that support, they don't have that person on their team. And I feel like in this role, we can look at that big picture and say, okay, not only am I your advocate and support, but I have this incredible network of team members that I can pull in from this side, and we've developed this safety net around you to help foster and empower you. And I am an absolute fan of working in this system. I think it's very exciting, and I'm so grateful to be here.
Thank you all. And each of our questions we'll get to hear like from 2 or 3 of you. And the first question is to describe an experience of health homes at its best. Would like to start us off?
Well, I wanted to share this client. I met him in one of his calls. Well, he was probably in the 70s or 70, 80-year-old, and one of his goals was to be able to control his blood sugars, and he didn't know why he had to go to the hospital several times, because he got either with hyperglycemia or hypo. And then I said, well, how often do you check? And he says, I don't remember. Okay, can I see your meter? I want to know why is it, maybe I can see how often you check. And he goes and brings me his meter, and I open it up, and it doesn't have no batteries. And so he was confused about checking blood sugars and checking blood pressures. So he did, for some reason, did not connect. And so to me, it's important that respect we show to our clients, and without making him feel like he was not doing, I said, well, why don't we call your doctor and figure it out? What are the expectations? What is it that you need to do? And so I called the clinic and generally said, well, he needs a little bit of teaching on how to use the meter. And so after that, when he come back for the next visit, he was so thankful. He said, I really didn't know what to do with this. And thank you for discovering that this is what I need to do daily. And from that day on, he was so meticulous, writing every blood sugar. He felt proud that he was able to know what he was doing. And to me, that was a very success story of this program.
Yes, I'll jump in. I have a middle-aged Caucasian male. I will call him Bill. That is not his real name. He lives in a cabin in the mountains about midway between Wenatchee and Lake Chelan. He's Medicare and Medicaid. He has diagnoses in mental health, borderline intellectual functioning, substance use disorder, and more. When I met him in 2016, he was going to the ER 105, 110 times a year. I found it overwhelming when I first started working, but I explained everything going on and all the challenges of distance, and my supervisor allowed me to tag team with a fellow care coordinator who lived up in Lake Chelan. And so my client, about half the time, went to the hospital in Lake Chelan, about half the time in Wenatchee Confluence Health. But he's been in every hospital in North Central Washington and had been barred from all of them. That was the history. And it was just too much for me to work with. And it was really cool that my supervisor said, okay, fine, use a second care coordinator. And each of us, care coordinator Lake Chelan and me here, we worked with the hospital administration and trying to come up with a plan. We did traditional stuff at first, trying to identify who to work, but that wasn't working. Keep in mind that my client doesn't own a car, doesn't own a computer, and has occasional cell phone service and occasionally has a cell phone. So he couldn't meet the ongoing criteria of, making your appointments on time, not missing any appointments. And so very easily and routinely was eliminated from service, forever. So what we ended up doing is working with administration and getting the administrators in both settings to agree to identify a doctor and a nurse in the ER, and in Wenatchee, a psychologist. And we were able to get Bill make regular PCP contacts and have crisis people identified in the emergency rooms. And what was just fantastic is that what we were able to get was, for the first time for this client, access to a psychiatrist or psychologist and treatment for PTSD and other issues. And that we had regular routine ER contacts. And we got him into substance use treatment for the first time ever. So this is huge progress for this individual. And of course, beyond the client benefit is that, you know, it's tremendous benefit, because in the past year now we're at 14 or 15 ER contacts. We're almost seeing a 90% drop in ER use. So from a system perspective, you know, tremendous success. And from a care coordination perspective, able to work with a colleague to truly meet this client's needs was fantastic. And so I think it's a perfect example of what care coordination can do with some of the more challenging cases that we have.
This is Midge, and I had a client who was in a skilled nursing facility. I had actually been acquainted with her before that, and I knew her to be a dysmic type of personality, where your life is kind of colorless, it's joyless, kind of chronically. So I spent time with her, and she had a large private room, and she had a cardboard table in there, and it was just full of stuff, and it was very disorganized. So one of her goals was to organize it. And I helped her do that one day on a monthly visit. And at the back of it, against the wall, was one knitting needle. And I asked her about that. And she said, the other one's in the closet. I never knit anymore. And I said, how come? Because my daughter doesn't bring me any yarn. I don't have any yarn. So I got her we called her daughter, and she wasn't able to bring anything at the time. So I got a community resource who gave a donation of some yarn. She started knitting. The next couple of months when I went in, the staff had kind of gotten involved too, and they were bringing her different colors. The last thing she asked me for was lavender, and she did her lavender. She'd done about 8 or 9 baby blankets, and she did the lavender one she'd been wanting to do. She became ill and passed away, but during that time, her personality became much more joyful. She had a goal, she had things to do, and she was also planning to contribute to, you know, local places that help children, babies. So she had something to do with her life rather than sitting watching TV and bemoaning life. And it was very satisfying to help her that way.
So thank you all. And I know everyone else has stories too. There's so many stories. Our next question is, what is the range of clients you serve, and how is it different rural to urban?
Well, I can speak a little bit for the range of clients. I am serving Asotin and Whitman County and a 1 or 2 in Garfield County. And their range, it depends on or if you're asking for age range or demographic range, but these folks, it's anywhere from 3 years old to, my oldest member is 88, I think. And they are predominantly, I would say I have about a third homeless population of trying to find homes for. And then, of course, all with chronic conditions, and maybe another third, some of the homeless with developmental delay or mental illness. And they're a diverse group in their, some are urban, some are in like the city of Clarkston, and there is no housing in Clarkston available for low income, no income people. It's a 2-year waiting list. And some are out in the outlying areas where they are no internet, no phone, some without electricity, some without water. So it's all across the board. It's everywhere.
I'll chime in on that one. The clients, when I first started as a care coordinator, I had a client base that was split. I had about half my clients that were in Stevens County, and then the majority were up in Ferry County. And Ferry County is way up at the top of the state, for those who might not know, and it's very rural. A lot of the burdens there come down to really the access of care. You know, we're going out to a home, and that might be driving to Republic and then going another hour out from Republic into a very remote, rural kind of setting. People living off the grid, people living with, you know, little access to transportation. So, you know, like Bill was talking about, making appointments is really a piece of it, kind of coordinating some transportation and getting them there. But often if they need an additional level of care, if they need a psychologist, if they need, you know, ongoing mental health support, if they have a health issue that requires them to go to a specialist in Spokane, that can be a real challenge. Coordinating that and, you know, kind of leveraging what might be available within the community to help with the transportation. Some transportation sources might not go to their home to help pick them up. So getting something local to get them to a point where they can catch something that's a little more, you know, accessible, and then get into an appointment in Colville or Spokane. That would be an additional challenge in that rural population. Clients that are in, like in Colville itself, definitely have an easier access to care and more availability of those community supports that are in that area.
And just to piggyback a little bit on that, is in the winter months, especially for our rural population, it's very impossible sometimes for them to get out. I've had transportation services not even want to venture over mountain passes or this or that, you know, just to pick them up to take them to appointments. So it does pose a challenge being out, and also getting them connected to the resources they need, like groceries, the simple things that being in a urban area you wouldn't have to worry about as much, because you could probably walk close to a store. Out in those rural areas though, it's really impossible. So they rely on us a lot to deliver services to them.
Some data with my clients include, I have 40 clients, about 35 out of 40 have some level of cognitive impairment, from mild to profound. I have 2 clients that are blind, several clients that are blind in one eye. I have 1 client that has a car. I have 1 client that has a computer. And about 3/4 of my clients right now have phone. So just real range of challenges across the caseload that I serve.
Yeah, and the same here. I have a variation, and I do work with Chilean, in the Chilean area, County and Douglas, and also Grant. I have probably 70, maybe 75% of Hispanic clients, and challenges there are a little bit different in the fact that they have, most of them don't speak English, and just teaching them the importance of keeping appointments, arranging transportation, and you know, for transportation to accept somebody else to go with them because they have fear of going by themselves. It is different in that area. You know, teaching them you don't have to wait until your next doctor's appointment to let your doctor know that something is wrong, that you are in pain. You don't have to wait 3 weeks. You can call now. Let me show you how. And it's just not one time, it's several times. And that's what we do, basically. And also, I do have a couple of non-vision clients, or they are legally blind, and a different challenge for them too. This program has taught me a lot, of compassion, and how clients are so strong, in the middle of what they're living in. I learn from them every day. So the age that I work with is from 2 years old to 95 years old. So it's a beautiful group of people. Thank you. So
we've heard a lot about these high-risk populations you serve and some of the challenges they're facing. So what is like a best practice for successful long-term engagement? Really trying to change the course of their health and life outcomes. So what's the best practice?
Personally, in my experience, it's respecting what they believe, respecting and meeting them where they are, and making them feel comfortable. And taking small steps at a time. Something that seems like so simple for anybody to call and make an appointment is not for many clients. So it's just discovering what are the barriers and how to connect them. I hope I answered the question a little bit. Thank you.
I think go ahead, Mitch.
I'm sorry. I like to use, as well as the relationship, developing the relationship is really, like I said, the most amazing part. I like to use the tools that they give us. Of course, we do the PHQ-9 every 4 months. That gives us an idea of how they're doing. I see with the isolation of the pandemic, I did see some of the scores increase, which means that their depression or anxiety could be increasing, the sense of isolation. But we also have the patient activation measure that shows us the level that they're at of their ability to participate. How much can we expect them to participate in their goals, and how much help do they need? Mm-hmm. Some of them are more independent. We sort of hand them the ball. We help find the resources that they need and hand them the ball. The others, they need much more help. Like Gladys said, they need a lot of coaching and instruction, and this is how you go about it, and you lead them, or rather, you don't push. I don't. I really follow what they want and try to be very gentle in my interactions with them and helping them to proceed.
I think a big piece of it centers on the communication, and that's the communication that we have with the member, and then also the communication that we have between those different supports that need to be put into place for that member. I think if we're working to coordinate medical supports, counseling, if we're working to coordinate food and housing access, opening that dialogue, because it's not something that just the two of us are going to be able to accomplish. For many of the clients, the goals are going to involve other team members and other partners in the community. And so having that communication, reaching out, keeping people informed of what the need is and what potential barriers could be, making sure we have consents to do all of these things. But obviously, having some communication with those partners that are essential for success is really a big piece of it.
I agree with everything I've heard. I'll add another element. That is that we are physically there with the client. You cannot see the bed bugs, the mice, or the rats, the mold, or the lack of food, or the fact that they're sleeping on the floor, that they don't have a phone. You can't see any of that unless you're there. My clients live in the woods, they live in cabins, they live in garages, they live in basements. That is tremendously insightful. That facilitates the list of things, that need to be addressed. Is about social determinants. You cannot address, weight loss and improved eating and healthcare until you've addressed the list of things I just identified. That is the norm. That is not the exception. That is the norm to the clients we are serving. I think being there and allowing the client to direct what is a priority for them is crucial to our being able to work with them and make it successful. You don't last long if you can't address those issues. They keep saying, yes, I'll see you again. Yes, come back. You're helping to address at least one or more of the things on those list of problems they're dealing with every hour of every day.
So I'm hearing about your coordination with others, and then also starting, I think, Bill, that was just a really good segue into some of the what's unique in your role. So our fourth question is about that uniqueness. It's like, what is unique or distinct about, health homes? And how does it complement the healthcare, other forms of healthcare case management?
Yeah, what I said.
Exactly. I think you already answered that one, Bill. That's what I was saying.
I'll be quiet.
Beautiful bridge. Yeah.
think
Can you
Gladys
repeat the
touched-
question, Teresa?
Yeah. Uh-huh.
I think Gladys touched on it too when she talked about helping them communicate with healthcare providers. They often have questions they're hesitant to ask. They don't know how to ask. I have clients call and go on and on about their pain, and we'll kind of review what is the doctor doing, but then I help them formulate their questions for the doctor. So that they can clarify their thoughts, because they're so into their pain or so overwhelmed by it that really, I think we help them. I call it a bridge. We're a bridge to other resources or to other providers to help. We bridge gaps, which is really what you were talking about, Bill, as well. But this is in terms of healthcare providers also, or counselors, getting them caregivers. And providing services like that.
Yeah, really getting them connected to resources in their area is a huge help that we give. I can't tell you how many times I've had clients who don't feel they're deserving of resources or help, and then I get them connected to caregivers, and their lives change. I mean, they don't realize what they need until they haven't. And so
that's right.
So it's helpful. I think we're very unique in that way, that we connect them to the things they don't realize they need.
Mm-hmm.
I think I'm hearing also from many of the providers that I'm working with in representation and advocacy for my members, that I'll call a doctor's office or a mental health professional or a COPES counterpart, and they say, oh my gosh, I'm so glad that I hear somebody that I can talk to, that I'm concerned about this person. I'm concerned about my patient. I'm concerned about my member. I'm concerned about them. And I didn't know who I could reach those concerns out to, because I'm not getting a response from them. They don't have a consistent way to communicate, or it's, there's some kind of barrier in making that connection. And so being able to be that liaison back and forth between what we can see of the trust and relationship we've built with our people, and then hear it from another provider's side, and then take that information back and communicate that, help foster that communication, I think is a really unique role of this, the spot that we're in. It's an honor. I feel it's something I write to all of my introductory letter to all my people. I am truly honored to have the opportunity to work with you, and I feel that way with both the healthcare providers and the members that we're working with. So I think it's very unique in that way.
Also, one thing that I find really fun is helping them with bills, because I can often get immediate results, and that's like, yay, like ching ching. One of my first visits with a man, he signed up when we were able to visit. He signed up that day as I talked to him. I said, what can I do for you? He said, I have 3 bills that aren't covered that I think should be covered. I called, I've even asked to speak to a supervisor. I'm not getting anywhere with them. They wouldn't transfer me to a supervisor. I use 2 words. I always gently, I say in those cases, I assist her as an advocate with a state-sponsored agency, or a state, contracted agency. And the words advocate and state together, I have had probably 3 times. Oh, let me fix that right now. That was a mistake. That was a technicality. That's even happened with a phone bill. She'd gotten the runaround, and I did a 3-way call, and the minute that I said those, they transferred me to a man, and before I could even say anything, he said, I got that covered, no problem, we'll have a refund. So that's fun, because they like that.
And what a great thing, just like some of those little wins that, you know, and just because of your role, your role can open doors in a lot of different places and help that coordination come together. So you have a lot of people you work with and coordinate with and bridge to, both the clients and then out to other care coordinators. So what advice would you have for working well with health homes and care coordinators like you?
Could you repeat that, please?
So think of all the, like, what advice would you have for working well with health homes? I've got some other partners here on the call. You've got agencies you work with. So what advice do you have about working well with health homes and with care coordinators like you?
You know, I've had that question asked to me from like the local clinic here, and they are aware. The member that we're talking about or working with is has some particular challenges related to keeping appointments, related to following through on instructions, and it's important if their desire is to maintain independent living. But if they can't stay on top of their health, then that's not going to be a possibility. The answer, I think, centers on, you know, again, communication and not being afraid to ask. I was talking with that physician, and they, you know, said, well, you know, I don't think that this is something that would be possible. And it was. It was actually an avenue that we utilized regularly in working with members. So being able to, you know, have an open conversation and not being afraid to ask, because if it isn't something that we maybe do, it's maybe something that we know about, because a care coordinator tends to be pretty knowledgeable about the resources in an area, or, you know, different people who are doing different things, even if it's not a resource that we've connected with directly. So I would encourage a conversation, encourage, you know, reaching out.
Yes, I'll add in here that about 99% of the time I'm reaching out to other resources. My frustration is that maybe only 1 out of 100 times are those resources reaching out to me for help, whether it's a clinic or hospital or ER. I rarely get reached out to, yet I'm involved in all aspects of my client's life. Again, those social determinants are huge to understanding what the client may be capable of doing and what kinds of support resources they need. So I'm working on this end on behalf of the client, but rarely do other systems reach out for our help. And I wish that would change, because again, I'm in the home, or I know where they're living as a homeless person, or I know the systems and structures that can assist the client, or help create them if they don't exist. And so, you know, for the most part, I'm doing that on my own, but often it's after the fact. And I wish other systems could reach out to us as care coordinators and use us, because we address more than just the medical issue, or more than just, you know, one particular issue in their life. We're looking at all the issues. Often summarize my elevator speech is, I collect resources, I help problem solve anything, and I am their advocate. And every client understands that. That's what keeps them interested in me coming back. If all those resources in the community understood that I did that, then they would be calling me much more, saying, how can you help? That would be a tremendous system breakthrough.
I think it would be, if I had any suggestion, I think to remember that we really all have the same goal, and that is to take care of our people. Whether it's the provider or, the case manager or the care coordinator, we are all wanting that person's best care. That's what we're working towards. So there's a lot of little things that can get in the way, and you can get frustrated, and maybe this consent doesn't have exactly the right verbiage, or maybe there's communication breakdown. But if we look at it with the long-reaching vision that we want the best care for the person, then we can all work together collaboratively very easily, really.
That sounds like an invitation to all those on the call and all those listening. That's really a great invitation. And look, you work with people like you, that's pretty awesome. And I know, like, in that best interest at heart, part of that is both you want better outcomes for the client, and then as a system, you want to have a return on investment. You want to have, decreased, overall long-term care costs can go down as well. So our final question in this round is, like, what's the return on investment? And this is an investment that's been going on, I think Caroline said, since 2013 from the state. So what's the return on investment, and in the long run, what do you see?
People having better quality of life. In that aspect, if we're not just focusing on the money, I think just the quality of life becoming better because we're helping them to gain that independence. I think that's a huge investment.
And is there a link between maintaining their independence and cost of care?
Well, there certainly is with my client Bill, when I describe, over 100 times a year before care coordination. And in this past 12 months, it's 13 or 15 or 16, something like that. I don't know the cost of an ER visit. I'm sure it's tremendous and it differs from client to client. But if you can cut that by 90% from that kind of use, then certainly the hospital has to be ecstatic about that. My pleasure is that the client is getting those emergency services better met, and there's more prevention going on. So my client's life, I can see the profoundly positive impact on this individual. And while Bill may be an outlier in terms of the most extreme need, certainly is representative. I know I'm seeing the quality of life of most of my clients improve in an obvious way over time, and know that translates into cost, even if I can't measure it from my end. Savings for systems.
All right, and that I agree, and I will be very brief. I think prevention is very, very important in here, and it plays a important key. Just for a client to be able to know that actually he is able to find a cane or a walker, or something to prevent a fall. I think that is a huge saving. If we are helping them to teaching them how to take care of their health, and they are more in control of their needs and their health care. So I think from that perspective, we have made a big difference in both ways, health-wise, economic-wise.
I think that the work that we do has a ripple effect in the community, and how that affects the community might vary from member to member. I had a case where, well, and I still do work with a gentleman. When we started, he was about 54 years old. He'd been on the health home program for about 1.5 years. I met with him for the first time at a homeless shelter in the wintertime. And he had a goal at that time that was set to reduce his smoking. Not quit, but just to reduce the amount that he was smoking. But he had some significant health conditions that he was not getting addressed because of access and issues like that. He was living at the homeless shelter. Well, he was at the homeless shelter at that point because he had a storage unit that he was living out of, and he was routinely being harassed by law enforcement I had been called many times to go, as his advocate, kind of help and see if we could navigate through and avoid going to jail, and find something alternative for him. But he had no ID, and he had no social security card, and he had no income. And so peeling back those layers and kind of finding out from him more information about what were his barriers to, to moving forward, let alone quitting smoking, really kind of unearthed these other things that needed to be addressed. And so through leveraging other alternative financing sources in our community, we were able to get him a ticket so that he could go to Spokane, so he could go to the Social Security office, get his Social Security card. He had Social Security income. And then we were able to find him stable housing. And at this point, he's been living independently in his own stable housing for almost a year. And he's engaged in dialogue with our job search coach. He's wanting to be employed. He's finished a dental treatment plan. He's got his health stabilized. So, but the cost in the community, I mean, law enforcement's not getting called. He helps out locally to church and volunteers. And he's looking actively for work to, become a part of this community. So I think that's one case, but it speaks volumes about the potential for this program and the partners that work with it. That wasn't, that's not one person that can help somebody go from point here to point over there.
That's such a beautiful story of ripple effects and how it shows up in one place, but then what the barriers are just it creates a whole different story to unfold, So I want to just open up. We've had all of these awesome questions for you, and I'd like to invite everyone to turn back on their cameras so we can see you, and we'll get a chance to take 2 or 3 questions from the group. What questions do you have for our awesome care coordinators? And you can just go ahead and raise a hand like this, or put up your raise a hand flag and unmute yourself. Yeah. Joey.
Yeah, I got a question for Bill. He talked about one of his clients having problems with substance abuse, and I was curious how his recent recovery coach training may have helped him with that.
Thanks, Joey. Well, the recovery coach training was fantastic. It was a review of a lot of the skill training that I had as a counselor, but it was very insightful in terms of community resources and new contacts for me. It's really only been a couple months, so I can't identify that it's changed my interactions just in the past month or two, given the isolation of the pandemic. But I think it certainly buttresses the amount of resources that I can now draw on that I didn't have a couple months ago. And again, with my client Bill, what we got him was the first time ever, inpatient substance abuse. What we got was, referral resources for him that had never been utilized before. So I think the training opportunity that I got was fantastic, and certainly broadened and deepened the toolbox that I have going forward.
Who else would like to ask a question? Yes, Kaylee.
I thought I was muted from your end. I'm curious how often you all encounter people who are friends of your clients or in the household who could really benefit from that health homes type model that don't qualify for the program. Like, how many rising risk folks do you see that if we had a program in place that could help those folks? I'm just curious what the numbers are, what you see out there.
I think there's probably one for every client I see.
I
There's
agree.
somebody who needs additional help, but they don't qualify because their PRISM score doesn't meet.
Oh, yeah, and that's the minimum at least. Yeah, it's probably much more than that. Sometimes the one of the couple qualifies and the other one doesn't, and they both have the same needs and the same health problems.
I agree with what both of you just said. Just about everybody lives with somebody or more than one person. They're doing it to get by. They don't have the financial resources. They don't have the support structures. They don't have the housing. And when I meet with my clients and I'm aware of the others, I see no difference. I mean, they have medical problems. They have the same kinds of social concerns and issues and crises. And why one qualifies and the other doesn't. Every year I come in and ask my supervisor, if so-and-so, is in the system and we just haven't tagged them yet. And typically they're not. So I can't explain why they don't qualify, but at least one-to-one, for every client I see, there's somebody else in that setting or that works with them or is around them that has similar needs.
I've gone to see a member before, and they've had somebody they invited over to find out more about the program and how come they don't get that help. Ask if it's something that they might qualify for, and then through asking a series of questions, you can discern that maybe they don't qualify, or you can take it in and have it checked out and find that they don't qualify. The challenge with people in the household that might not be on the program is that I think if you could work with all of them, there's in some cases a better success of moving people forward with their goals. If those goals are supported by the people that are closest to them in their household, or if they have a shared type of goal. A lot of this, getting more exercise is definitely something that's easier if somebody's going to do it with you, and following a diet or a schedule. Making small lifestyle changes that really can benefit people with chronic health conditions really does hinge on not only that person, but what else is happening within that household. So it would be supportive for many people.
So there's a question in chat of, does Health Homes have enough team members to cover the languages spoken? And Spanish, Russian, Ukraine. Is there specialty Health Homes providers for tribal community members? And then also the, I know you can access interpretive services. So languages.
That's been something that our organization has worked towards. We have delivery that's available in Russian, Spanish, and English, which supports most of our members. We have had recently some members in Moses Lake that speak Arabic and use the interpretive services successfully to explain the program, have them opt into the program, and then continue working forward with them on their HAP and their goals.
Yes, I've not been given permission to speak for the agency. It seems like we have a number of care coordinators who speak Spanish. I suspect we're doing adequately there. I have several clients that claim Native American heritage, and part of my 4-month reviews is to ask, am I meeting your needs, from your culture? And so I note that. And so far, they don't complain. I have a little bit of training with Native American cultures. That does not make me an expert. I've been trained well enough to at least ask the question, am I meeting your needs, and then to document that. And if they weren't, then I would find a way to reach out.
Jump in around the whether there are any health home providers for our tribal community members. I did look into this because I noticed on the health home dashboard that the organization Native Project out of Spokane was listed as serving folks in Okanagan County. But based on the data that we received back for people served in our region, they are not currently serving anybody in Okanagan County. And I also looked into whether there were any health home leads that were managed by any of our tribes in the state, and to my knowledge, there are not. But I will dig in, or I see Kaylee saying maybe one. I don't know. Feel free to jump in, but that's something that I was curious about for our Colville Reservation community.
Caroline, this
Yes,
is Deb.
go for it.
I'll just speak as a lead organization in the Health Home program. What we are told is we have to work very directly with the tribes, to contract directly with the tribes, that all tribes are given first right of refusal to be their own lead organization and manage their own health home clients themselves. If they don't want to be a lead org, they can opt to contract to be a care coordination organization, and then hire tribal members to serve. There's also slight differences in who is able to serve the tribal members. So it is a challenge that we are still trying to overcome at the state level. My understanding right now is the Makah tribe on the coast is the only tribe that is actively delivering health home services to tribal members, and maybe in a follow-up email to participants, we could send that video that I sent you about the Makah tribe. We are very interested. I know there's some tribal liaisons on the call today, and Action Health Partners as a managed fee-for-service and AmeriGroup lead org is very interested in conversation with tribal members up in the Colville area and even over to Spokane, so we could help there.
Great. So one of our goals in this session of demystifying health homes was to increase partnerships and opportunities and connect people. So we are going to send us into some breakout groups here, and our goal is to see both what did you hear is important, and so I will put this in chat for you.
I was going to just let you know there is one other question in the chat with someone else.
Okay, there's one more question, but I'll introduce this thing and then we'll grab that question in chat. Thank you very much, Kaylee. So like what did you hear is important? And then also, what do you see as possible working with health home partners? So some of the possibilities that we can explore. And then I'm going to give you the question here, because once that's answered, that'll be a good one. So as a provider, how would I know if someone is involved with health homes?
Collective medical helps to keep hospitals in the loop, I believe, because they contact us if they've been admitted to a hospital emergency room. With doctors' offices, I find they don't have a clue, and every time I talk to one, I'm re-educating them on, or for the first time, educating them on what health homes is, if they're interested and have a minute, because they're not sure what it is. When I go into nursing homes and assisted livings, which I have a percentage of, at first they sometimes view it as a duplication of services and question. So I present them with some of the literature from the state, and I spend time talking to them and educating them about the program. But I do think that that is an area that could use some work.
Good. And that's part of the things we're working to identify, so that's great.
Yeah, every time that I call to advocate for a client with a medical provider, I always present myself and give a little bit of information about the program and what we do. And it's a very busy, clinics are very busy, and sometimes you don't have much time, but at least put the name of the program, Health Homes, and my name, and kind of to see if that is written. Sometimes the medical assistant says, oh, I will put your name and information in here, so we have it. Yeah, I think it is something that we need to keep working together with this here in this area.
And Kaylee's put in chat that health home eligibility is found in Provider 1. So it's good to thank you.
I'll just mention one other thing. If you're wondering if your client is Health Homes eligible and you know that they're a Molina or an AmeriGroup or CCW client, you can always contact those insurance companies and they know who they're serving in the Health Homes program. And for AmeriGroup and dual eligibles, you could always contact Action Health Partners because we're the lead for the 11 counties and we could let you know whether they are eligible for it or active.
Great. So I'm going to send us on into breakout groups of 3, and we'll just have 7 minutes, like what did you hear is important, and then what are our opportunities to move forward with to improve care coordination. So welcome back, everyone. So what did you hear? Like what's important, and then what are the opportunities? And please feel free to either, we can hear in the whole group and be putting things in chat, please. Go ahead and raise your hands if you'd like. Kaylee.
So our group talked about, one of the participants in our group, the most surprising thing that she heard was that there were other people that didn't qualify, that there were a large number of people that didn't qualify for the program that could use the program, that don't fit that criteria. And how big that is, that it's, you know, parents with children or children and their parents, spouses, friends, roommates that all need these services. But it's not available to them. And then the other thing we just kind of quickly threw out that it seems like the Health Home program sees things that other traditional folks don't see because they're out in the community. So they're in those homes, that it meets the social needs of the clients. It also gives them hope for life. It gives them something to move toward. And it finds barriers of help that won't necessarily be uncovered by others. I think that's about it. Anything else, you guys?
One of the things that came up in our discussion was sharing more about what the Health Home program is and what care coordinators do, and that just overall better awareness of that, and then, you know, people understanding what the role of the care coordinator is really could help move things forward.
Other folks, opportunities, what do you see? Yes, John.
Yeah, our group spent some time talking about the communication connection between providers and care coordinators. It's amazing that even though this is a medical one and it was through HCA, that Health Home still has to do cold calling to find their clients, and that there's no good way to do any kind of warm handoffs. And providers, partly that providers don't know about it because in some ways they're not really in the loop in the project. You know, they get educated on it, but at that point they're not an active partner in it.
So what do you think?
Can I just piggyback on what John said? Is, yes. And our conversation was very similar in that it wasn't, we recognize that there needs to be more partnerships across the board. And we use providers interchangeably with organizations, but recognize when we say providers, when we're talking about doctors, nurse practitioners, and PAs, for the most part, many of them don't have the time needed that those patients for that warm handoff. So we should start to focus on like the MAs, even beyond the nurses, the MAs who spend so much time with the nurses, even just chit-chatting before the doctor even goes in to see them, and can pick up on triggers for some of those areas that need more care coordination or need more help because of some of the social determinants that they may speak about during that unofficial talk. So how do we include not providers or providers and nurses, but even, you know, the front desk and MAs or others along the line to really help recognize when a patient needs more care coordination and could be potentially a Health Homes client.
Yes.
Our group discussed the importance of cross-training care coordinators with the Recovery Coach program to include more tools in their toolbox, and also the importance of having someone available to visit the clients in their home setting.
Margie.
We talked about the need for education about health homes program in the communities. As a nurse, I worked in the area for years, and when I was contacted about health homes, I had no idea what it was, and yet it's been in the state since 2012. So that was something that we focused on, as well as sharing resources with care coordinators from other health homes grant organizations. Because we often, our care coordinators themselves will find a resource that's very helpful and opens up a new avenue for our clients. And that would be something that would be interesting to share across the board, you know, communicating with each other. Have you found a resource for this?
Mm-hmm. Yeah, Tim.
In our group, actually, for me, you know, I'm Washington 2-in-1, so we, you know, we have a kind of symbiotic relationship with, you know, health home workers, because, you know, we can help identify resources and use that. They can use that as a tool to help, you know, connect people to resources. But, you know, they're so key in communities because, you know, again, they are the in-person contact. You know, they're there to identify truly the needs that that person has, that they might not even know that they have. And also they're that person that communicates on their behalf to, you know, this very complex system that they have to navigate. So, you know, people can call 2-in-1 and we can give them resources and send, you know, and help them. And we have people that are kind of similar where, you know, they'll talk them through and assess their needs online. But that's, you know, that's only so much we can do. We need more health home workers, though. They're actually on the ground helping individuals in person. We also discovered that people still don't know what 2-in-1 is, and that we could be a huge resource for health home workers. And we'd love to increase that partnership.
Yeah. Great. So our next question is, do you have questions you need answered? Do you know who your partners are? And then we're continuing on this, you know, what are our opportunities to improve care coordination? So do you have questions you need answered? And you can put those in chat, or we'll just take them live. Do you know who your partners are, and what opportunities are there to improve this coordination of care? I mean, that one's an ongoing one here. We've had some good input already.
What do you mean by do you know your partners? Are you saying do you know your resources? Are you saying do you know who you're referring clients out to? What do you mean by that?
So you may be in a place like, how do you know how to work with health homes? You know, do you know, like who are the partners that you're needing to coordinate to get a specific thing done for a client? You know, how good is that like network of care coordination that gets your client to, you know, where you want them to be or where they want to be at a reasonable cost of care?
I think Gladys is trying to speak, but she's muted.
Gladys, you're muted.
Hello, sorry. Yes, so what I was saying is on the first appointment that we have with our client, usually we have a list of the partners that the client is working with. And from then it depends on the goal that the client we like to work with, it adds up new partners, and that's how we work with this.
So you'll have a list of partners for each of your clients.
Correct.
Mm-hmm.
That also, though, kind of is a working, morphing process. I mean, when you start with somebody, they might have a primary care provider, or they might have somebody that, you know, that they're engaged with in counseling. But through the course of working with somebody, that list may change. They may develop, you know, a need, or you might help identify, or they might express that they have a new need or something else that they want. And so you're always adding to the, usually adding to those partnerships of things that are going to support that member.
In the small group, I was just mentioning how helpful I think it would be for some of our folks in treatment that are in substance use disorder treatment to have someone going into their home and really being able to support them, being able to see their environment, and connecting with the counseling team, whether or not the information adds up, and what other things are they struggling with. Make sure that our treatment plans align with each other. And so, you know, I was wondering, I had asked Bill if he had had any contact with his patient, Bill, and he said that no, he had to initiate every contact. So as a provider, I'm not sure who to reach out to, even if it says that they have a home health, and trying to figure out which one and who. And I certainly, I can see the disconnect for actually the counseling team doesn't even look up provider one. That's done on the billing end, you know, so there's not even the people who would be initiating having another partner to wrap around their patient. They wouldn't even see that information. So I recognize that, but I can see, you know, I'm looking forward to recovery coaches and you know, people being able to help us with our patients, because they move around a lot and they have a lot of needs as well. So not just on the medical side, but, you know, on the counseling side.
If I can just speak to that, that is definitely a challenge, what you're talking about, Loretta, for sure. And one of the successes I've had in having providers understand who that care coordinator, that health home person is that when I have someone I'm advocating for, I send a fax to that healthcare provider. It goes into that patient chart. They can pull it up. And so I've been on the phone with doctors or PAs or RNPs they say, okay, I see this is who you are. Here's your contact information. This is what we're working on, and being able to really coordinate the services that need to be, whether it's for a hearing evaluation or an MRI or whatever it is, that if they have that data and the patient chart, then it seems that they have good access. They have a name, a phone number, and a release to be able to communicate back and forth. It does require, you know, some legwork and making sure that ensuring that it gets entered in the chart and it went to the right spot and all those things. But that at least is something a provider can open up on their desktop and have access to.
So this is Deb. I wanted to interject that it has been slow coming, but we have slowly started to build relationship with some of the bigger health systems, and doing care conferencing with some of the high utilizers of the ED. And I know Kaylee can speak more than I can about it, but to be able to participate in a care conference and in real time be able to look up if the health home if the person is eligible for health home at the time. And I don't know how to effectively or efficiently expand that out into the community, but there could be some level of that. I did a social service kind of tour when I was in DC in 2018, and the community of DC actually does have a community care conference meeting fairly regularly, primarily around the homeless population, where all the service providers come together to ensure that they're not duplicating services, but they're wrapping around the client. So that might be a possibility for the non-healthcare providers too.
I'll just piggyback on what Deb said. I've been going to the quality mental health kind of care conferences that are held at the hospital where we talk about really difficult clients who are frequenting the ED, and we try and come together as a group to formulate a plan around these folks. And it's been really helpful to have myself and a representative from Molina and the other MCOs, so that we can kind of look that person up in real time and figure out whether they have health homes or they have, you know, they could be case managed, and then really coming up with a plan so that everybody is on board with, you know, what happens when they present to the agencies the next time. It's been really helpful, and I think very, very helpful to the providers. Tom Ettinger, I think, is part of that group, and he has really found some benefit, I think, in knowing that there are other services out there that can possibly help their clients through care coordination. I'd like to see more of that. I'd like to be invited to more of those kinds of care coordination conferences, and I think it would be really important for providers to know when their clients are in the program, if they're eligible, so that, you know, maybe they've been approached about the program and they've declined it because they didn't think that they needed it, but a provider knowing about the program could say, you know, I really think this looks like a good program, maybe you should give it a try, and get them involved that way. And I have lots of ideas, but that's just, you know, a few. I just think that we can collaborate more, and we can be at the table, and we can help, and we can in real time look and see whether they have eligibility and how we can help.
I saw your comment, and I'm wondering if you would be able to speak a little bit more to, from your perspective in the clinic, like what was confusing? What kind of confusion did it cause for you to know that there was a health home care coordinator working with your client? Or was it that you didn't even know they were there? I think it's like, I really appreciate that you're being honest, because we can't figure out how to work better together if we don't just put out there what's frustrating, what's not working, and what needs to be fixed. So can you help us understand what could work better from that perspective?
Yeah, the audio blanked out for a sec, but I think you were talking to me. Is that right? Okay. So, you know, this was actually a couple of years ago, so I think things have evolved. But a couple of years ago, one of the health homes contractors was a community-based organization. So, oh my gosh, sorry, I keep getting these alerts. It was a community-based organization, and I was a primary care provider, nurse practitioner in a clinic system, and I really saw the need for care coordination for my patient. And my FQHC system, Family Health Centers, we were also starting to provide health home services at that time. So Family Health Centers had some health home patients, and then this community-based organization also had some health homes patients. And I tried to refer my patient to the Family Health Centers health homes because, you know, that made the most sense to me. But it turned out she was already signed up as a health homes client with a community-based organization. So just that kind of thing, you know, so basically I found out that my patient had this health homes coordinator for many months, and I didn't know. I had no way of knowing. I can't know what I don't know. So, you know, it just seems like what someone brought up earlier, maybe one of the first things I would recommend a health homes care coordinator doing is ask the client, who's your primary care provider, and just reaching out to that person to say, hi, I'm working with your patient.
Great, thank you.
Suggestions or questions, and then I'm going to have us come back into some breakout groups, and then looking and seeing now what actions make sense for me and my organization, like what actions make sense for our region, and then we'll be coming back with kind of that action list. And I know that it's like what makes sense for me, and so that's just like in your role, whatever role you're in, what makes sense. And then also looking, more broadly than that. So it might be for your organization or for the region. Okay. So let me send us on into breakout groups, and we're just going to take like 4 minutes for that. Welcome back, everyone. As we're coming to the latter part of our call, I really want to encourage us to be using chat. So like what's next for you personally, as well as for your organization or region. And then we'll also be able to hear it from here. And if there's specific requests, that for, to, the accountable community of health or just to the overall, our overall system, like we can make requests here too. And then Caroline will help us to close, just be speaking up to some of the next steps. So please go ahead and put your actions into chat, and then go ahead and raise your hand if you'd like to share in the whole group. I'm going to pick on Sherry to share what she was saying in our group.
Thanks, Teresa. So one of the things that we were talking about was about not just informing the practitioners. I think that it's important to provide more education about the Health Home program, and specifically the role of a care coordinator and how a care coordinator can help, as a part of a team. It's always a team. But also I think that dialogue needs to include the schools, particularly this year with a lot of members that are, school age, helping them navigate if they have an IEP in place that provides for, an individual education plan that provides for maybe counseling or physical therapy support services at school. It's been tremendously hard to work to get those provided in a home setting, or to come up with a solution to help that be supported for this individual in a home setting. And so, including the schools in the dialogue so that they know that a care coordinator could be involved in helping a family work with those type of supports is important as well.
So my takeaway is that having the front office and the billing staff, when they are looking up on Provider One coverage, when they see home health on there, to be able to earmark that so that then we can track down who they're working with and try to reach out, have patients sign releases and reach out to who their provider is.
Go ahead and unmute yourself if you'd like to share. Yeah. There's lots of good things happening over here in chat too.
I'll share. This is Deb. As a community-based lead organization, we do recognize that there's a lot of community organizations that do similar services. And so how can we come together with healthcare? How can we facilitate some sort of a process flow to recognize the intersections of where our programs intersect, where it's important to ask, where it's likely there's a health home eligible person there, that kind of thing. And I think it started, this is just a shout out to John Chapman, but I think it started in the early TCDI work group of the ACH. And so I think we can kind of revisit that again for community-based care coordination and just see how we better partner. And I also throw out that I think there's a huge opportunity for health home care coordinators to work more closely with the newly forming recovery coaches. It's a win-win for both of them. The recovery coaches have the true lived experience that maybe not all the care coordinators have, but the care coordinators have the educational experience and the lifetime experience. And how do we marry that together closer and better, I guess? I want to piggyback. I just saw Kathleen's comment about the payer. I would say that is the biggest challenge, right? We are a managed fee for service. So a lot of those clients stay managed fee for service. They don't leave us, but we're also the AmeriGroup MCO lead org. And with clients, with members being able to switch health plans every 30 days, sometimes they're on our AmeriGroup list and then they switch to Molina and they get switched over to Molina. And then sometimes they switch over to coordinated care, and there's just all of this flip-flopping back and forth. And that's can pose a challenge in some ways. On the other hand, most all of the CCOs contract with all the payers. So there's still continuity available for the client care coordinator relationship. And that shouldn't change, right? But you don't know that because you have a hard time knowing if your patients are members, right? So again, that data sharing, finding out who the care coordinator is really important.
So Caroline, would you like to just go ahead and what have you been hearing today? What feels important and what would you like to see next?
Well, there's a lot of things that I think are nibbling on the edges of this issue of the knowing who is eligible for health homes, so that those of you in the community, including those of you who don't have access to Provider One, right? Like our social service partners are not going to be able to log into Provider One to check. How do we figure out a system, given what we have, right? We have to be realistic with what we have. How can we come up with a process that would work for most in terms of figuring out eligibility? And I think there's an opportunity for us to co-design that with Action Health Partners. They can try to come up with a process, but they may not know what your sticking points are. So if we can get some partners at the table to help us co-design, I think that would be our quickest way of getting to an eligibility check. And you probably saw in the FAQs that right now there isn't a good way for anybody to look up. There's also not a good way for people to refer anyone to health homes, because all of that is done behind the scenes, kind of under the radar. The assignments are made by the healthcare authority. So there's complexities to the way the program has been constructed that make it really tough for people on the ground who are trying to partner to improve health for their clients. So I think that's a really great place that we could work on together. Another area that I think it was Midge who was talking about really knowing the resources as a care coordinator in your community. And this is kind of related to 211, and I know Tim needs to hop off, so I'll make sure I follow up with him. But I know, like, in the spirit of transparency and honesty, I know that some of our providers struggle with 211 and getting really relevant information from there for their clients. So I think there's an opportunity for us to mine the gold that all of you care coordinators have in your brains and improve the inventory of resources that people can use, and anybody can use them, right? Like if we actually improve the validity of results in 211, that would go a long way. That would not just help health homes, that would help anybody who needs services, including the rising risk population. So I think there's a lot of opportunities, and if you want to put in the chat, I think an immediate next step that I'm going to start organizing is figuring out this front door to the health homes, like an eligibility check process. If you want to help co-design that, please let me know so that I can add you to the list and invite you to whatever that looks like. I'll be working on that with Action Health Partners. And yeah, I think I'm gonna look through everything that you put in the chat. There's probably many more opportunities. And so my job as the project manager is gonna be to kind of glean all of that and figure out what we can do concretely going forward. I just want to give a huge shout out to the fishes in the fishbowl. Care coordinators are awesome, and you're doing amazing work. And I think when I think about the promise of the Pathways Community Hub, right, like it was kind of a promise or a desire to bring that kind of care coordination to the rising risk population, to those who aren't yet costing the health system a ton, but who have a bunch of needs, like all the family members and friends that you mentioned for your clients. And we're not necessarily going to get easy checklists or outcomes from today's conversation, and that wasn't the point. The point was really to deepen your understanding of the program, because if you don't get what something does, you're not even going to bother to figure out how to coordinate with that thing. So that, like, I think a big purpose of today is to deepen people's understanding of the program, and we'll make sure to include this recording on our website and distribute it widely so that people can take the time to listen to the recording after the fact. A lot of people had to back out because of the fires, and we'll make sure this knowledge is shared widely. So other things I encourage you to reach out to me about as we think about building a strong care coordination network in our region. Are there other programs that we need to know more about as a community? Could we do another fishbowl for another program? Are there things that we need to know more about, or ideas that you have around care coordination? Are there some sticky issues we've been avoiding, right? Or that seem insurmountable that we really need to address? Like, if we're going to get this done, we just need to come out and talk about it and be honest and figure out how to overcome those barriers. And then what would help you and your local community get further, and what can the ACH do to help you, right? We are here to help build stronger systems and build capacity. So I am all ears. I can't do it on my own. You know, you're the experts about what's not working. So I value your input, and I really look forward to hearing your feedback. And I value honesty, so bring any feedback you want. Yeah, I think that's all I'll say, Teresa. And Teresa, I want to thank you for co-hosting this today, and Deb and Action Health Partners for helping plan this event, and the rest of you for being part of our care coordination network. So I really appreciate all of you. Thank you.
Thank you. And let's give a hand for our care coordinators. Thanks, everyone, and take good care.